Well, thank you guys all for coming. This is a great crowd. So I know a lot of people in the room. There are some new faces as well. Just kind of raise your hands real quick. How many EMRs? EMTs? Advanced EMTs? And medics. So a good group. I think it actually represents what we would find on a cardiac arrest in terms of the percentage of skill sets that are there. So I was telling the group before that this is sort of the going to be the first lecture, sort of the didactic portion of some CPR training that we're going to be doing over the next few months throughout the district. It's really exciting stuff. I've been working on this for a little over a year, both at the state of New Hampshire level and in Vermont. And the idea of this is how can we do some simple things, it's not complicated, but there are some steps you have to take to really improve how we can deliver cardiac arrest care in our area. So just want to acknowledge a couple of people. Doug Kupas is the state medical director of Pennsylvania. They did a lot of work statewide about 3 years ago there and have really improved their survival rates. He was sort of an influence to some of the stuff we did. I did a lot of work with him in when I was doing stuff in New Hampshire. Matt Scholl is a medical director of Maine. Him and I actually put together the team-focused CPR thing that you guys see. That we kind of worked on that together. Also, the Heart Rescue Project is a Medtronic-funded foundation there. Do a lot of work with several states in terms of measuring and improving cardiac arrest care. And the Seattle Resuscitation Academy, a lot of the information is taken from them as well. The group of us from northern New England, Vermont, Maine, and New Hampshire went out there in March to do a lot of training. They're hopefully going to be sending a few more people out from Vermont in each state on the next round this fall. It's just a great experience as well. They've actually, both Heart Rescue and Resuscitation Academy are helping out Vermont, New Hampshire, and Maine in terms of setting up our own resuscitation academies and delivering high-performance CPR. Mickey Eisenberg, has anybody heard of him? He's sort of one of the modern fathers of resuscitation, I guess. He's the medical director for King County EMS in Washington. Really, really interesting guy. Some of the information is taken from his work here. Just a phenomenal experience to go out and train with him back in March. So what are we going to talk about today? There's a lot of pieces to cardiac arrest care, but the part I'm going to focus on is what we're going to call high-performance CPR. We're going to talk a little bit about some epidemiology, some evidence-based care. How do we put that evidence into practice, and how do we organize our cardiac arrest care to really improve outcomes? So, who cares about this? Cardiac arrest patients are the poor survival rate and a very small percentage of calls. Anybody know what percentage of calls are cardiac arrest calls? Can you take a guess? 5%? Anybody else? 2? Is that a 3? That was like a gangster 3. I like it. 3%? 2? Yeah, it's about 1%. So not a lot of calls that we deliver. Also, our survival rates overall in the U.S. are pretty dismal. Overall, it's like 10% or less than 10%. But it is the leading cause of mortality in industrialized nations. It kills more people than AIDS, lung, breast, and prostate cancer combined. About 350,000 deaths a year, about 1 every 90 seconds somebody has a sudden cardiac arrest. This is kind of how I thought of cardiac arrest care when I was working as a medic back in the 90s. If we showed up, unless somebody had a cardiac arrest in front of you and we can defibrillate them, if we showed up on a cardiac arrest, they were generally dead. We definitely had this sort of nihilistic attitude that you show up during cardiac arrest, the outcome isn't going to be so good. And I think that was probably true. I think this is changing because we're really starting to learn what can make a difference. CPR is over 50 years old. Anybody know who this guy is here? Oh, sorry, this guy. Paul Saphir. He is considered the father of modern resuscitation. You ever know what he invented? I don't know if it's at the rescue dinner. They may remember the conversation. Mark, you went to school with that guy, didn't you? He invented the oropharyngeal airway. So a lot of the stuff they did in the 1950s, he was at Johns Hopkins, they did kind of resuscitation research. That occurred in the operating room. What's interesting is this right here is the fire chief for Baltimore City at the time. So EMS has kind of been on the forefront of this all along. I really don't believe that, probably since around 2005, we really didn't understand what really made a difference in cardiac arrest care. What's also pretty amazing is the chances of survival fluctuate as much as 500% depending on where you live. And it's not like people have better protoplasm in Seattle. It's just the systems they have in place to really improve outcomes. The big thing take-home point for this lecture is we have to get away from nihilism, right? We have to get away from seeing a cardiac arrest patient and saying they're dead. We can really, if we have a positive attitude that we're going to resuscitate these people successfully, I think we'll be very successful. And this is really important, especially for the transporting services. Survival rates, they serve as a benchmark for overall system performance. They really do. We're entering an era in transport medicine where reimbursements are going to be based on outcomes and not on mileage. They're really going to start to look at an EMS system and see how your outcomes are. And cardiac arrest is a great example of this. It's time critical, it's time dependent. You have multiple EMS skills. You need teamwork, coordination of multiple stakeholders. Care and outcomes are measurable. It's very easy to measure how you're doing. And EMS is a strong influence in outcomes. So if you do cardiac arrest well, it's very likely what we'll do STEMI well, stroke, sepsis, trauma, all the other systems of care that we think of. Cardiac arrest is kind of right there with it. So it's a good benchmark for overall system. It's really not magic either. The stuff I'm going to talk about today, there's nothing really spectacular about it. There's not like any magic fairy dust that they have out in Seattle they're sprinkling on people. But it's not easy either. There are a lot of links to the chain of survival. If I have phenomenal early defibrillation or in CPR, but I don't call 911 and I call 3 relatives before I activate 911 and there's no bystander CPR, we're not going to make a difference in outcome. We're really not. There's something that I talked about in some other lectures called the slope of death, and it's basically that you have a 10% decrease in survival for every minute that there's no intervention started. It just goes right down. So at 10 minutes, if nothing goes on, you're dead. So all the things that we do, early access, early telecommunicator CPR, early defibrillation, high performance CPR, all those things really kind of decrease that slope of death and kind of increase survival rates. Let's go over some evidence. So the most important determinant of perfusion is the arterial pressure generated during chest compression. So if you think of chest compressions, and this is an important concept, when you push down, think brain. When you release that release phase or recoil phase is heart, because the heart perfuses up diastole. So brain, heart. And that's basically what we're doing to save people. When you stop chest compressions, perfusion pressure is lost immediately. And we know that VFib can be maintained for long periods of time if you have really good quality CPR. Some of the problems that we're having now with high quality CPR is people are like stuck in VFib. You just can't get them out. This refractory VFib. Christine, that call you had the other day, how that guy was in VFib for 15 minutes straight? Kind of a long time. You think that after 5 shocks you'd be able to convert them. And people just get stuck in ventricular fibrillation because good quality chest compressions. We had an anecdote, a couple examples I give. Keen Fire saw a patient 2 years ago in Home Depot, witnessed cardiac arrest, immediate bystander CPR, great CPR, EMS got there, worked him in the aisle of Home Depot, he was still gasping. Gasping means there's perfusion to the brainstem, and that's a good positive indicator. They called the hospital about 30 minutes into the cardiac arrest and said, he's still in VFib, he's still gasping. They shocked him multiple times. When we finally transported the patient with good high-quality CPR, they didn't use lights and sirens. They had the stretcher. We used to ride the stretcher. It looked really cool, but they had the stretcher down, doing good compressions. We finally terminated care. The guy was in a systole without cardiac activity in the ER. An hour into it, he was still gasping. And that's something that we just never would have seen before. And that's all good chest compressions. Anybody know about this case? This was a national, of course, these are the stuff we read about in the news. This guy witnessed cardiac arrest. He was in a rural area of Minnesota. They actually lined up all the people in town to do their 2 minutes of CPR on him. Refractory VFib. They kept on working him. The Mayo Clinic helicopter got involved, and do you know why they kept on working him? Besides VFib? It's another indicator they're measuring. Paramedics should know.
End tidal?
End tidal. Really good end tidal, really high, and that tells you there's perfusion, there's circulation in the body. So they kept on working him, and then on the 12th, after 96 minutes, he converts after the 12th shock, and he walks out of the hospital alive with no neurological deficits. That could not have happened when I was practicing as a medic because we did shitty CPR. We did a lot of stuff to interrupt chest compressions. Sorry for the little girl with the bad look. All right, so this is an example of that losing perfusion pressure. So it takes about 15 or so chest compressions to get to a good enough perfusion pressure. This is the aortic pressure. So what happens when I stop compressions? It goes right down and you have to start over. And that's why we know that interrupting chest compressions is bad. I kind of think about like pushing a car that's out of gas and in neutral. First, when you start to push it, it's kind of a pain. They start going, it gets easier and easier. It's sort of the same concept of moving blood around the body. So this is what we want to see when we show up at a cardiac arrest, right? Good, hands-only bystander CPR. Unfortunately, this is what we see often. Anybody know what the bystander CPR rate is in District 13? Take a guess. What percentage of patients? 1%? It's better than 1. It's about 20%, 24% I think we had. It's in the 20s. What's really interesting, you go over to Cheshire County, you know what the rate is over there? It's about 70% last year. And I think the reason is, it doesn't mean it's good CPR, but the reason is they're very aggressive on the 911 side about trying to chest compressions. Vermont's going through some good changes right now. The 911 is engaged in this process, and that's one of the things they want to start measuring, being aggressive on, so hopefully we'll get better with CPR. So this is what we often see. Why aren't people doing bystander CPR? Anybody know? They're afraid, they're worried. What else? Wait, they're afraid of being sued. Maybe he looks like a lawyer, right? So.
They'll wake up and say, they're not trained.
Not trained. What else? What's one of the things we train people to do as part of CPR?
Oh, respiratory aspiration.
Yeah, mouth to mouth. I don't want to do mouth to mouth. So they looked at this, and that's actually one of the reasons people say, I'm very reluctant to do mouth to mouth. Well, how long does it take to ventilate a patient? It's important. And think about interrupting chest compressions. This has been looked at. It's a layperson. It's about 16 or so seconds for them to ventilate. Medics are really good, but it still takes about 10 seconds. So if you think you're a single respirator to go back and forth, it's a lot of work to do those ventilations. So this is an example of a 30-2 model with 16-second ventilations in the pig model. And you see our perfusion goes up, and we have good perfusion here. This is cerebral perfusion and coronary perfusion pressures. I stop to ventilate, they drop, I have to build them up again. This 16 seconds is a huge gap. It's almost as big as that chest compression time. So the question is, do we need to do ventilations at all for some of our cardiac arrests? If you take the same model and you're just going to do continual chest compressions, you're going all the way through. You're perfusing the brain and the coronary arteries, heart, lung at the same rate, same effect. So some of the stuff I'm going to talk about here is not. When I say it's not in the EMS protocols, our Vermont EMS protocols follow the AHA. What's really great is the AHA is buying into what I'm talking about today. They left a lot more wiggle room in this cycle, and they said, well, there's a passive ventilation option. There's actually a page. I know like in ACLS now that you can develop your own sort of CPR plan. So they're really starting to let local systems develop, as long as they're using their concepts, develop their own sort of protocols. So some of this stuff, I really wouldn't start using a lot of this stuff until we're ready. But this is sort of the introduction to this. But I think a lot of the concepts you can start using. Yeah.
There's something I've been muddled about. Hands-only CPR. Okay, continuous CPR, good CPR, you have continuous perfusion. Where does the oxygen come from?
Oh, hold on tight. It's going to be, so yes, hands-only CPR doing chest compressions. Where does the oxygen come from? I'm going to get to that. So that's great lead-in, but the answer is people are going to be ventilating during the process, and I'll show you why. There's also more than one way to skin a cat. There really is. It's really interesting to me because people are passionate. I'm going to talk about cerebral resuscitation, and Robert, that's kind of what you're talking about. What you do is you put them on a non-rebreather, and you're doing CPR, so they're passively ventilating just from chest compressions, the air going in and out. Some people are really passionate about it. Other people, the Seattle model, they do continuous chest compressions, and they bag every 10th compression. They just do a little puff of air during it. And then there's 30-2 that we've all been trained. And I think all of them really work. I really do. I believe it's more the concepts of doing great quality CPR. These all work. The reason that I'm a fan of the continuous chest compressions and ventilating every 10th compression, which I'll talk about, or cardiocerebral model, that passive ventilation, it's just kind of easier. And it's easier to remember and simpler to follow, especially when I looked at this at a statewide level. I'm working on this in New Hampshire. It's a little more training to do some of the other models, so that's why I'm a fan of it. I'm a big fan of keeping things simple. All right, so chest compression fraction is an independent predictor of survival. So chest compression fraction is the percentage of time that your hands on the chest, that you're doing CPR. So what does the AHA recommend for chest compression fraction to be at? What percent? Anybody know?
At least 70, suggesting 80%.
Yeah, so they're actually saying 60. I think, to me, that's bananas, because I have, we have EMS units that don't have a ton of training yet, that we provide medical direction for, that I started getting the data from. We're using Zoll monitors over at Cheshire, and I've had one code so far out of, not a ton of codes, out of 8 that was below 80%. Is where so I always look for 80%. We can get this up to about 90 if you're doing a great job, but I say at least 80. What's the optimal rate? What should our chest compression rate be?
118.
118? 118? You're in the range. What does AHA say? What's the range?
100 to 120.
100 to 120, yeah. So this has been looked at. And remember, we used to say push hard, push deep, push fast. Now they're saying, we might be going too fast. So I consider myself an expert in resuscitation. I got out of my EMS fellowship, started my job over at Cheshire Medical Center. We had a CPR challenge. They came in with a mannequin, and we just did CPR. What do you think my rate was? Take a guess.
80.
140. 140, because it's so easy to go too fast. I find that it's less often a problem going too slow, we go too fast. And this has now been looked at, and we know that if you go too fast, you don't allow enough filling, and you're not getting perfusion. So 100 to 120. I'll talk a little bit about metronomes too as we go forward. They're a must. What's the depth supposed to be? Yeah, 2 to 2.4 inches. So don't go 2.5, 2.4 inches. Recoil is, I think that's one thing that we really, I'm going to talk about the person who coaches metrics and make sure that the mechanics of CPR are done well. Recoil is the thing that I think we have to correct the most, because when you get tired, you start leaning on the chest. And when you lean on the chest, what you're doing, if you push down, remember brain, that heart phase, when I release, if I don't come off the chest or really have that good recoil, what recoil does is it brings blood back into the thoracic cavity. Because we'll talk about firefighters in the room. When you prime a pump, what are you doing? Yeah, remember you're taking the air out, so you're creating a high pressure to that low pressure, right? That's how air comes in. Sort of the same concept. It's funny that I am like, so don't ever let me do anything firefighting without supervision because I'm really bad at it. But I was in a pump class and I'm learning about, and I just could not get the concept. And finally they're like, Doc, it's like CPR. You're kidding. Like high pressure to low pressure. And I'm like, oh, okay, that makes sense. So it's the same concept. All right, so avoid leaning on the chest between compressions to allow chest recoil. And the study that came out last July, that came out actually after these guidelines were ready to be published, that found that this is an independent predictor of survival. Perishock pauses. So how do we normally defibrillate a patient?
Stop CPR, get away and let it assess.
This is it, right? Shock advise. All right, we're all going to back up. We're watching.
We've been doing CPR.
All right, watching. Don't touch the patient. It's going to explode. And then we're going to shock. Everyone clear, and shock, right? So that's how we used to do it. Now, though, you really want to do chest compressions while charging. The reason we were so freaked out before we had pads and we used paddles. Anybody like older medics in the room? Mark Considine. Anybody you ever seen paddles arc, Mark? When you put on paddle pressure and the arcs, totally patient lights up. You can see why somebody get hurt. The pads just really don't do that. There are EMS systems around who are actually doing chest compressions through defibrillation. I'm not advocating that, but we should at least get on the chest because you want to keep it as short as possible. But there's a big study that showed an 18% decrease in survival for every 5-second increase in pre-shock pause. So that means while you're getting ready to shock, you should be pumping on the chest. I would recommend picking a number. 25 chest compressions is a good one. Some people use 15, but as a system, we can just say, we're going to do, when I'm going to charge that monitor, I'm going to do 25 chest compressions before we decide to shock. The monitor, especially the LifePak 15, charge it really quick. But at least that gives you, we're ready to shock. You're not going to, the charge isn't going to, it's going to still be there waiting for you. But you know that I'm going to do 25 compressions starting now as we're charging. All right, 25 done, shock, and get right back on the chest.
What about the analysis phase?
So for an AED, you can't do CPR during analysis. Some older AEDs, if you do chest compressions while charging, it'll shut off. It'll disarm it. You have to know what your machine is. I'm pretty sure like the one I have in my car is really old. That's probably one of those ones. But all the newer ones, you should be able to do it. I don't know if you guys know models or anything, but that's something we can figure out, what you have and how that'll work. All right, let's talk about ventilation. So the AHA says 30 to 2, or 1 breath every 6 seconds if you have an advanced airway in. They now have a passive ventilation option for 3 cycles. We're going to do 4. That's the most common protocol that's used throughout the country. Sufficient tidal volume just to produce a little chest rise. You don't need very much. And the 30 to 2 is interesting to me, and it's the concept that if you practice with 30 to 2, when you ventilate, so the person doing chest compressions, and they're doing their 30, and they're gonna ventilate. They're at 28, 29, 30. They count to 2, and they start again. You shouldn't even be looking at that person ventilating. If they can't get in their 2 breaths in those 2 seconds, it doesn't matter. Because we often look, or you got the ventilations, and you stop. So it takes a lot of practice. Another option we're going to talk about is continuous chest compressions. So you're going to do 2-minute cycles, chest compressions only, and ventilate every 10th compression. That's another option you can use. That's sort of the Seattle model. When we did this in New Hampshire, and Vermont and Maine are looking at the same thing, we were going to do 1 every 15 compressions. That's the Pennsylvania model. They've had a lot of success with it. Do you guys know we switched to 10? Because we're lazy, we want to use all the videos from Seattle, so that's what we're going to do in our online rollout. Vermont's probably going to use as well. We said it doesn't make that much of a difference. Let's use 10, we have the training material. So we chose 10 for that. What does positive pressure ventilation do? And this positive pressure ventilation kills people in cardiac arrest. It really does. It increases intrathoracic pressure. So every time you ventilate, you're pushing air and you increase the pressure in the chest. We talked about high pressure going to low pressure. And now the blood, when you have recoil, it's fighting to get in there. You're not going to perfuse as well. You can't get that negative thoracic pressure to recoil, and you decrease blood return to the heart, to the thoracic cavity, and you decrease perfusion pressures to the brain and the heart, the coronary arteries. And if I have a cardiac arrest, and say medic shows up or AMT intubates or put in a supraglottic airway, who do we usually put on the bag? The new guy, right? Because they just squeeze a bag. And you can tell them, just do 1 breath every 6 seconds. And at first they're probably really good. At first they squeeze too much, right? They get all the air and they squeeze, and then they're looking at this person doing this in front of them. So what do they start to do? Squeeze, squeeze, squeeze. So it's really easy to hyperventilate patients. And that's another reason to do every 10th chest compression, because at least you have sort of your own timer, your intrinsic timer to ventilate a little bit. Speed okay? I'm not going too fast? Okay. So hyperventilation equals death, right? Cardiac arrest is a low flow, low pressure state. You don't need a lot of oxygen. And this, to answer your question, this is where some of this comes in. Don't need a lot of oxygen for these patients. It's low perfusion. So the thoracic pump model, we used to think when you do CPR, you're kind of compressing the heart against the sternum and the back of the spine. It probably works just more changing pressure in the thoracic cavity. So high pressure goes to low pressure, and the same is really true for air. So if you're doing chest compressions, you're also ventilating the patient. This brings us to cardio resuscitation. It's been around a while. 2003 came out of University of Arizona Heart Saver group, along with Tucson Fire, was a partner with them. And this is their protocol. It's the original protocol. They did hands-only CPR for bystanders. They showed up. They used number of compressions. So we're in Pennsylvania. We're going to use minutes. So they did 200 chest compressions, rhythm check, 200 rhythm check, rhythm check, etc. And then when they get down here, it's consider endotracheal innovation or advanced airway management. And for their first 4 cycles, there are patients on a non-breather and passive ventilation. How do you think their results were? Great data. Their survival rates went way up. Although Arizona had really low rates to begin with, they went from 8 to I think 15%, or maybe 30% of what they did. So big change for them. Madison, Wisconsin had a lot of success with this protocol as well. A lot of it is probably not so much the protocol, it's performance. Performance, not protocol. Is that people are, anybody know what the Hawthorne effect is? Hawthorne effect is I'm going to study something and we're going to do an intervention. So I'm going to do all this training on cardio resuscitation, get everyone excited about it, and people are working harder. So naturally, it may not be that the intervention really did it, it's that people are really motivated to do a good job. And it's a beautiful thing because it gets people excited about resuscitation. So this is the protocol that we're going to be using down here. I suspect Vermont will be rolling this out probably over the next year. I did talk to Dr. Wolfson today, and he said go for it. He said that's kind of in line with what we're going to be doing. So we're going to be kind of the guinea pigs for the state to start using it. Hopefully we'll have bystander CPR. EMS arrives. You put an oral airway or nasal airway in. You do a passive ventilation option. If you think it's cardiac, you can put them on a non-breather. For your overdoses, trauma, you think it's a respiratory arrest like asthma attack or COPD, you don't want to use passive ventilation. Just hasn't been studied in that population. Use a bag valve mask, but either way, 2 minutes of uninterrupted chest compressions. Your analysis, 2 minutes, 2 minutes, 2 minutes. Either non-breather or bag valve mask every 10th compression. We keep it simple at the epinephrine. So often we're like, has it been 3 minutes? Has it been 5 minutes? Just give a dose every other cycle, and that's going to put you in that 3 to 5 minute range. For the medics, consider antiarrhythmic. And then after your 4 cycles, that's when you discontinue passive ventilation, start bag valve mask, or just consider your advanced airway. And that could be a King tube, could be an iGel, could be a BBM. You just want to continue the non-breather at that point. Is it a must that you can never do airway management in here? I would say no. I mean, there are scenarios if somebody is just filled with vomit or there's an airway issue, yeah, you got to take care of it. But your bread and butter codes, when the airway, you have good, compliance with a bag valve mask, we're going to wait till 4 cycles. Make sense? There's going to be a lot more training on this. So this is what we know about cardiac arrest care so far. We know that early effective chest compressions decrease blood pressure and extends the time that we're in VFib. Interruptions and chest compressions, bad, worsens outcome. Excessive ventilations increase intrathoracic pressure and decrease blood return to the thoracic cavity. Cardiac arrest is a BLS event. It really is. ACLS is really sexy, but it just doesn't work. None of the interventions have been shown to make a difference. Reduced hypothermia, or what we call targeted temperature management. These are the patients who get return to spontaneous circulation for VFib attack, improves neurological outcomes. This is stuff that doesn't have to be initiated in the field. It can be initiated in the ER or tertiary care. We know that population, that makes a big difference. So how do we put this evidence into practice? Cardiac arrest is a BLS event. This is a big concept. BLS owns resuscitation. They really do. There's no evidence that ALS interventions improve outcomes. All providers have a huge role. So by BLS owning CPR, what that means, if your team is doing really good chest compressions and Drew shows up and wants to put in an endotracheal tube, and at some point he can totally do that, but he can't interrupt chest compressions to do it because BLS owns CPR. If they're going to start IV access or an IO, they're not stopping chest compressions to do it. That's the whole idea, is that BLS team is focused on doing good resuscitation, and the ALS providers do their interventions around it. Make sense? High performance systems have a VFib survival rate of greater than 50%. So everybody in VFib lives. Now we know that that's not necessarily going to be true, but if the mindset is they will live, these patients are gonna do better. Recent cardiac arrest we had earlier this year was a gentleman in a restaurant, had a cardiac arrest, was a VFib, refractory VFib, had been into their fifth shock, still gasping. It was an ICU nurse who witnessed it that did CPR right away. Fire department got there, did great CPR, and then they called into medical control. The nurse threw her hands up and said, he's dead, it's been 30 minutes. And I said, that guy is not dead, that guy will live. Sure enough, he left our ER talking. He was totally fine. So again, good CPR. How do we normally arrive on scene? And this is a little different depending on the agency. But say, how many are on an engine that go to a cardiac arrest? 3? Oh, that doesn't really help me that much. So, sorry. Say you have 3 people. So,
Great, now you do.
Gee, so how do we normally show up on a scene?
On a truck.
Thanks very much. Thanks. When you get there, what do you do?
Grab the equipment.
Yeah, you get your stuff, right? So you come out, you grab your equipment. If you have the personnel, this just depends on how you're staffed. If you have your personnel, some people will advocate that you have a provider that just has a pair of gloves and goes into that house and starts CPR while people are bringing the equipment in behind them to shave off maybe a minute. So some systems are doing this. It may not work for everyone, just something to keep in mind. If you have the resources, that's probably if you can get that first person there to get hands on chest. Clear some space. How often people love to die in the smallest bathroom possible on the 3rd floor walk-up, or we all know these houses where you're like, I can't work in here. This may be drag them out to the porch, get them out of that space, because you're going to need space to work. So it's really important to quickly clear some space and develop your own sort of ICU or ER to really develop that system around it. You want to briefly check for breathing or agonal breathing. Gasping, again, is a great thing. It means there's perfusion to the brainstem. Perform a brief pulse check. If there's no pulse, start CPR immediately. Use a defibrillator when available. When you apply that defibrillator, again, minimally interrupting chest compressions to do it. You want to get it out pretty quick. So your initial assessment can be pretty quick. Obviously, this is a perfect scenario because it's a small room, but
Now blow me.
pretty much right away. And if you're not sure, if you feel a pulse, I think I feel it, I'm not sure, it's okay to start CPR. You're not going to kill people by doing CPR. Continue chest compressions, rhythm check every 2 minutes. The reason we chose 2 minutes versus 200 chest compressions is we found that 2 minutes, especially for your AED timer, is really helpful. So that's some places the compressions needed minutes. Put your airway in your oral or your NPA, passive insufflation option with a non-breather, or VDM, one breath during recoil. Or if you try during recoil, well, it doesn't really matter. It's every 10 compression, a little pump air. There's an emphasis on high-quality chest compressions in 2-minute cycles, a rate of 100 to 120, depth of 2 to 2.4 inches. Complete chest recoil is really important, and you want to rotate compressors at least every 2 minutes. You can use a minute if you have the staff available to do it. It's tiring to do 2 minutes of CPR and minimize interruptions. So your chest compression mechanics, this is something that we all think we do well, but I think it's really overlooked in terms of how important this is. And really important, you want a good depth. See how he's almost coming off the chest here? Good recoil. And you want that rate to be, again, between 100 and 120. And you've got to find a way to use a metronome. A lot of people have smartphones, there's free apps. It's really important because it's so easy to lose track of what your rate is. And then when you're on the side of a patient, you want to keep your knees almost to the patient. You want to keep yourself at a 90, almost at 90. Knees are right here, this 90-degree angle here. You want your upper body to be moving as a unit, sort of like a fulcrum. It's funny because this is stuff I think that a lot of us just say, it's the CPR part. We used to say it's not the important part. It's the drugs and all the other interventions, but this is really where it's at. All right, and we know that a lot of us are superhuman, but you got to take people off the chest. 2-minute cycle is real important. We may not have the resources. I mean, Heidi, you go out in Dummerston before Rescue's Air.
I'm alone.
You're alone, so you may not have those resources. You may have to use family if there's somebody young there, young enough to do those, not also cardiac center. So why are there so many interruptions in chest compressions? What are we doing as EMS providers or
Interventions.
And
Stuff, right?
stopping for everything.
Yeah, you're putting in IVs, you're moving patients, intubating or airway management. We don't have any mechanical CPR device in our system, but putting those on interrupts chest compressions as well. So in terms of the airway, there's no evidence that airway management changes outcomes or improves survival in cardiac arrest. If you're going to place them, just don't interrupt chest compressions to do it. I think if you're going to intubate or put it in a king tube or an LMA, it doesn't matter. If you want to just bag someone, you're having good compliance, again, it doesn't matter. What you do want to do is you just want to make sure it's not interrupting anything else you're doing. The reason for the delayed placement, people often ask, well, we have a great team, why can't we put the airway in right away? It's because I believe as a system, you really want to focus. Those first 8 minutes of a cardiac arrest are really critical to improving survival. You really want to focus on what makes a difference first. And it's a little hectic in the beginning of a cardiac arrest, right? It takes a few minutes for the dust to sort of start to settle and get things organized. When you don't interrupt chest compressions when that defibrillator is charging, you want to continue the chest compressions while charging and get right back on the chest immediately after shock. Hovering is huge. This is where you want to be. You don't want to be across the room. You want to be waiting to start chest compressions right away, shock, and get right back on the chest. If you're going to put an IV or IO access, I love IOs because you can put them in the tibia and it's kind of away from this area we call the CPR triangle, which I'll talk about. You can put them in without interrupting chest compressions pretty easily, but again, not going to stop CPR to do it. Drew's shaking his head. How much is an IO? It's like $100.
$20.
Yeah, put in all the IOs you want if you want to rest.
Thanks, Doc.
We have a medical record.
Really want to work on scenes. I think we do this really well in this system. Some systems out of Just history, just don't do this really well. You're going to save a patient by working them where they are. We know that moving patients interrupt chest compressions. You can see this angle here, that's not good CPR at all, right? They have to stop CPR to get them in the ambulance. And we know the quality of CPR in a moving ambulance is really difficult. There is nothing the ER has that's going to save these patients. EMS is where it's at. I mean, it really is. And you may be stuck for a while. I mean, there are resuscitations that can go on a long time. You may have to phone a friend and call the ER and say, we're still in VFib, what the heck do I do? And there are some tricks that we can talk about for refractory VFib, but it's really difficult. Yeah.
Hey, Doc, you said the ER has nothing they can do to save this patient, but if we're running an ambulance with 3 people, 1 driver, 2 in the back, and you're talking 2 minutes of compressions, and then you swap out, the ER's got people, so
Yeah, so it depends.
don't we want to get there
If
fast?
you're already in the ambulance, I mean, so some people would, a friend of mine used to be the medical director in Austin Travis County, basically made the comment that I don't care where your patient has a cardiac arrest, stop and do resuscitation right there, because interrupting compression force is outcomes of moving ambulance, blah, blah, blah. Where do you think the next cardiac arrest happens? In the ambulance bay, as they're backing into the ER, and the staff's like, bring them out, and they're like, no, Dr. Hinchey said we have to do CPR right here. They're trying to resuscitate the patient. So, he would say, when somebody would even say in an ambulance, you're going to pull, if somebody goes in the back of the ambulance, there's 1 person, you got to pull over and both tend to the patient and get help. But often here, if you're already on scene, you got a couple of guys from Brad Fire, 2 or 3 from rescuing, you often do have enough resources. If it's a resource issue, it may not work, but you often have the resources.
I was on Christine's code Monday, and it became a fatigue factor. I mean, Christine didn't do many, because she was doing her thing, but there were 4 of us, and it became a fatigue factor. Yep. Kudos to the Brat Fire guys, they went way above and beyond. So I think there's a point where you need, more people need to show up, or, you're not going to have good compressions if the same 4 of us are doing it for 45 minutes.
And every situation, I mean, these things are not written in stone.
Right.
There's also like, you show up the crazy family, it's not a good patient out of there no matter what, it's not safe, whatever it is. So you can't write these rules in stone, but in general, if you're going to make a difference in outcomes, especially you guys may be fit, the best thing to do is work them there. And there may be situations it's just not going to happen, it's not going to happen, it's not going to work, you fatigue, whatever it is. But in general, it's going to be there, it's going to be the best place to resuscitate where they are. The city of Portland, one of the big things they did when they changed their cardiac arrest care was they used to transport people pretty quick. They worked them on scene, they tripled their survival rate in a year just by working them where they are. Mechanical CPR devices, they're sort of interesting. There's been 3 big trials, the CERP trial, paramedic trial, and LINK trial. One was a autopulse, the other was a bit of water.
Behind you, the 4 models.
Oh my gosh, you guys are fancy here. Thank you for the conference. Thank you. The 3 trials really show that there's no difference between that and high quality CPR. My issue with them, I think they're good. If you have to put somebody, that would be an example, Sal, you have to put somebody in an ambulance or the fatigue factor kicks in, I think you can apply these. I just wouldn't do it until after 4 cycles, because again, those 4 cycles are just critical into getting the resuscitation started, or focusing on it and not interrupting chest compressions. Make sense? People love these devices, though, they really do. Yeah, I tried to get them not to do that. People ask, because these are like 30 grand, 20 grand, so they're not cheap either. No. But what the AHA says, manual chest compression remain the standard of care in treatment cardiac arrest. I always say if you have the resources, save your money. Capnography is really important. Remember, at the advanced EMT level, some of you guys have exposure to this if you have the monitors. What capnography basically does is when you breathe in oxygen, you exhale carbon dioxide. So that oxygen goes into your body, gets pumped out, goes to the cells in the periphery, exchanges the oxygen for carbon dioxide. Carbon dioxide is sort of the waste product, goes back and you breathe it out. So if you get that number is high, that means there's perfusion or the cells are alive. These are the people that we show up in their asystole to kind of, we found granddad on the couch, we think it maybe been up to 30 minutes, we don't know. And their end title is like 8. That's because there's nothing alive in the body. If it's 50, it says, wow, cells are alive. So the nice thing about this, it kind of tells you how viable the patient is, and it also tells you if there's return of spontaneous circulation, because if I'm working cardiac arrest, my end title is 20, the first thing you'll see when the patient gets ROS is it'll shoot up to like 60. And you say, ooh, that must be ROS. That's usually the first thing you'll notice, that number change. Remember, you can also use it in a bag-up mask. We often forget you can put it between the mask and the bag. And you can also track this. Their patient who has low numbers here, they get return of spontaneous circulation loss, they lose loss of spontaneous circulation. So that kind of in and out of ROSC, you'll see those numbers change. And drugs that improve survival after cardiac arrest. And take a guess. Nothing. During cardiac arrest, I should say, after, maybe after. So really nothing does, so they're really de-emphasized. When you're going to give them, I recommend epi every other cycle. Keep it really simple. Don't interrupt chest compressions to do it, and then use your antiarrhythmics per protocol in the medical. If you get return of spontaneous circulation, it's really important to remember, do that 12-lead EKG, because if we identify a STEMI, that's going to launch the air medical transport to the hospital's LZ, depending on where you are. So that kind of changes what you do. We'll call them their STEMI alert. All right, good so far? Let's talk about sort of the pit crew CPR, incident command CPR, team focus CPR, whatever we want to call it, same kind of stuff. So this is just a way to choreograph cardiac arrest training. What's nice about it, it's not a one-size-fits-all. It just really defines the importance of roles. It focuses on priorities, and it's all the stuff we've talked about. Limiting interruptions, good depth, good recoil, control of ventilation, timing defibrillation, addressing fatigue, and continuous reassessment. Think about your equipment before the call, your local services. It might be that you say, we're an advanced EMT crew, we have an IO kit, we only use epi in cardiac arrest. Why don't we package our epi with our IO kit? These are just examples. What are my default monitor settings? So when I turn on my monitor, at the ALS level, do I have to find the end tidal? And that, you want to know if that end tidal is going to come up right away. What setting do you want it to be under cardiac arrest? Maybe my end tidal I'm going to package with my BVM because that's when I use it. CPR checklist we'll talk about. We're going to develop one probably for probably for the system as well that rescue will carry. Do you have that with your monitor so it's available? And really, these are just examples. You can develop your pre-plans based on how your equipment is stored and what your resources are. Predefined team rules is hugely important. And I think, like when I talk to the fire service, we call it incident command CPR, because that's really what this is. You know your roles. Example, the first two providers who get there kneel on opposite side of the patients and rotate chest compressions. There's a team leader that sort of coaches the metrics. Probably the most important person. I'll talk more about that role. Practice makes perfect. You have to practice this. This lecture is not going to make you good at this. You really have to practice at this stuff. And when you practice, practice like you play. Wear gloves. Have your gear that you would normally have. Have your providers arrive. So, like, if I'm going to do a mock cardiac arrest in the parking lot over there, you might say, well, we're going to have, the engine's going to roll in first. If there are two people, then the ambulance is going to get there with two more. The utility is going to show up with one more. Kind of, stagger them in how you would normally arrive on a cardiac arrest and work that way in injury. Simulation training is really important. It does not have to be high fidelity at all. It can be a CPR mannequin. But it's really important if you have the ability for real-time CPR feedback. Some of the, like a metronome, some monitors like the Zoll X series actually will give you CPR feedback and tell you how your compressions are doing and what your rate is doing. Some people activate a lot of our monitors can audio record. So out in Seattle, they audio record all their monitors. And it's not discoverable. They actually written into their rules where this is only used for quality assurance purposes. And they can really listen to the medical directors and EMS command staff listen to all cardiac arrests to see how they went. And the medics have gotten used to it. They now talk into the monitor. And they'll say, this is what we're doing, and they kind of QA it. They take it so seriously out there that they had a multi-million-dollar lawsuit that the county lost that they could have won based on the information they got from the audio recording, but they couldn't submit it. So the county ate the basically lawsuit. They couldn't submit it as evidence because it's not discoverable. It's only quality assurance. But interesting concept. And ongoing quality assurance is really important. How are we doing on cardiac arrest? We have to measure it and see what we're doing. So this is an example of from a life pack. This is a life pack 12. You look every hash mark is a chest compression. And you're looking. This is the quality assurance piece after the fact. Looking at the call, and then there's a gap. What do you think happened here?
Putting in the airway.
Yeah. So the comment was the medic was going to intubate. He said, "Hold chest compression for 2 seconds," and that was it. So we have no concept of time when you're doing a procedure. I mean, if you're in the middle of something, you're in this time suck. You think it can take 2 seconds, and it took all that time. So there's little things like that that's really interesting to look at. This is data from the Zoll monitor. So when they had this set up, this was a call up in New Hampshire that we had. It shows you after the fact you have a CPR report card, so I can tell them their CPR fraction was good. It was over 80%. They had a great CPR death. Look at the rate though, almost 140. And what happened was their default monitor settings did not have the metronome on. We looked at that, we changed the settings, and the next code they had, it was 100, right on the mark, right where that metronome was. And then we give this is how we give their fraction was good, we give all their metrics how they do, because often we think we do a really good job, and we just don't have a clue until we look at the data afterwards. And this stuff's not meant to be like, you're a crappy EMS provider, you do bad CPR. It's just really meant to improve care and say, oh, maybe we didn't do so good, what can we do differently, how can we practice better? And use a metronome. Everyone has smartphones these days. I mean, these things are free. CPR Tempo Full Code Pro is actually an AHA app that has a metronome on it. You can document on it. You can actually press when you do an intervention. And I just use this thing when I show up. Just put it on. I set it at 110. I'll set it aside, and then people know what their depth is going to be. The first code I used this on in the hospital, I put it on. Everyone's doing CPR. The RT showed up, didn't know what it was, and started saying, you're going too slow in your chest compressions. And we all said, no, the metronome's at 110. So really, really helpful, because it's so easy to go too fast. And these are all free. I don't like, there's a lot of apps that are good. Alternate your compressors every minute if possible. Chest compressions while charging, hit hover, and you get right back on the chest immediately after shocking. And if you're using a manual defibrillator, pre-charge that manual defibrillator. So, all right, there's somebody coaching the metrics who's on that monitor ideally, and says, we're approaching 2 minutes. We're going to get ready to do a rhythm check. Get ready to switch your chest compressors. I'm going to charge the defibrillator. So they're going to start charging up before they even check what that rhythm is. Because often what a manual defibrillator is, we're going to stop CPR, up there in VFib, start compressions, now I'm going to charge the defibrillator. So that way you're ready to go, we're going to charge, ready to go, clear, up, they're in asystole, dump the charge. Or they're in VFib, shock, right back on the chest. So it just saves a step. I always forget this, I've been doing it a little more, but it's easy to forget, practice. And when you're doing ventilations, controlled ventilations, you just need a little bit to get some chest rise. See how he's only using 3 fingers, just a little puff? That's really all you need. You don't need to squeeze. That bag has a lot of air in it. You just need a little bit. Because remember, positive pressure and hyperventilation kills. Ventilation is not the important part at all. All right, so this is what I call the CPR triangle. You guys should have this in your handouts. And these are sort of the arrivals of different roles. And what I gave you are examples. We can look at this and say, that does not work for us, let's do this. Completely fine. I'll go through all these. So, 1 and 2 are your chest compressors and defibrillators. 3 is your airway guy. 4 is the most important person, I think. That's your coaching the metrics person. They are keeping the time, because they're on the monitor, so they're going to keep for 2 minutes. They're going to say, deeper compressions, good rate, good recoil, get ready to switch, kind of choreograph the whole thing. 5 is your meds. I put it down here thinking an IO. And 6 is like your medic, your code commander. They're kind of, ideally, do we have 6 people in cardiac arrest all the time? Not at all, right? This is if you have 6 people. And I'll show you how these roles can kind of blossom and grow. If you have the 6, this person is sitting back there thinking of big picture stuff, talking to the family, kind of organizing stuff. The way I think of this at an incident command level, this is operations, and that's incident command. So we all know no fire chiefs in the room. The person really doesn't do anything, right? Operations does it all, so kind of the same concept. So these are all examples. You can use BLS, can be EMT, it can also be EMR, ALS can be paramedic, it can also be advanced EMT. What if you only have 2 people? So you show up, you initially hands-only CPR. This is a great example of your passive ventilation, right? Because you don't have to have one person ventilating. You want to alternate 1 minute compression to position 2, shock if indicated, ventilate off cycle if you're going to ventilate. And this person attaches the AD, shock is indicated, alternates compressors. So they're going back and forth. That's pretty stressful. For your crew rotation with this, again, practice makes perfect. So this is they're using a bag bell now. So it's analyzing, and that's when they switch. No. Practice choreography is really important. What if you have 3 people? This is probably more similar to a model that we have sometimes. chest compressions and defibrillators. And then this person has a tough role. They're going to be filling all those roles. So this is where it gets tough because they're getting sucked into the CPR. If you get sucked into the CPR triangle, you also lose track. It's kind of like the Bermuda Triangle. You lose track of time and things get a little altered. So really, ideally, you want to have 4 to have somebody outside that triangle. And this is the 6th person we talked about. So chest compressions, your ventilation person, and if you have somebody bag valve ventilating and you're able to do this, what I often recommend is this person up here will just hold a 2-handed mask seal if they can, because that's a hard thing to do. And these people basically pass back and forth the bag between them, so they're ventilating obviously. Your meds, team leader, and co-commander. This is an example of a checklist. This is like when the dust settles, you have enough people, I'm going to go through and just make sure we did anything. So you want to have your co-commander pick the rules identified. Your chest compressions are, interruptions are minimized. Your rotating compressors, your metronome is on, it's set between 110 and 120. Pads are applied, O2 flowing and attached to bag valve mask or non-breather, how often we forget to plug the thing in. Your end title's on, you got IV or IO access, you're considering the causes, and you have family present communications being provided. When the code is over, if we terminate resuscitation on scene, which happens a lot, I really recommend a really quick debriefing. This isn't like the code is over, let's meet on Tuesday at the fire station at 5 o'clock. This is just a really quick huddle outside of the residence or wherever it is and say, what went well, what didn't go well, what can we do differently? And you'll find that you'll change maybe your pre-plans of what you do in the future going forward. So anybody do this right now? So Jeff, you do a little bit. It takes a few minutes. I find there's a lot of value in it just to kind of review a cardiac arrest to see what went well, what didn't go well, what can we do differently. That's really it. Just a quick way on it. And checking in. You may have some new providers, especially new volunteers who first cardiac arrest or winged out. And what also happens in our small communities? Half of these people we know, right? You know the families. So there's some positive parts to that because it becomes more personal. You're able to sort of be there with them and guide them through the thing, and they're more comfortable with you. But it adds emotion to it because you know them and you know the family, so it's a little more stress as well. All right, so what's next? So we're going to plan training throughout the district over the next few months. We're going to start with rescue because the idea is if we get our transporting service kind of trained up and then start disseminating the training to all the smaller communities, get Brad Fire on board pretty quick because they're pretty busy as well, and start working with them, get everyone else, and practice like you play and do it often. That's really one of the big take-home points. This is a free ebook. You go on to just type in Seattle Resuscitation Academy ebook, or you can find it on iTunes. It's a free download. It's interactive. There are lots of videos. There's audio clips. It talks about a lot of this stuff and 10 ways to improve survival of cardiac arrest. It's actually pretty cool. It took me like 3 or 4 hot tubs to read. It's really like a great read.
Say it, Seattle Resuscitation, what?
If you Google Seattle Resuscitation Academy, you can find it there, or it's on iTunes as well. Just called it 10 Steps for Survival, Improving Survival of Cardiac Arrest. Mickey, I think. And that's it. Any questions? Oh, sorry. Go for it. Questions at all? No questions? Good, bad?
I'm still trying to clarify my original question.
Oh, sure, go for it.
Because what I wasn't concerned with once you're doing CPR and you start to add oxygen. What I was concerned with is you're doing passive ventilations with hands-only CPR, bystander CPR if you want. How long can that be done?
For the passive ventilation?
For the passive ventilation for the person who's still adequately perfused. And is there any passive ventilation going on during that?
So if I understood your question correctly, you're saying that how long can we not be doing ventilations in these cardiac arrests before we have to start ventilations?
Right, we have some long response times here,
So
even if people are
what's
doing
interesting is, the answer is we don't know. That's the answer. What the AHA, they chose 3 cycles based on one randomized controlled trial, and nobody's really looked at the bystander hands-only CPR and then arriving and starting passive ventilation. We just really don't know the answer to it. The reason we picked 4 is that's the most common protocol used when you look at cardiovascular resuscitation. I suspect it probably doesn't matter because you're ventilating the patient anyway, and we know that it's such a low perfusion, low oxygenation state that even having sats in the 70s during these codes, it's probably okay. But that's all supposition. We really don't know is the answer. But there are rural systems using this that are very successful. Pennsylvania is an example. They have some very rural, remote areas of Pennsylvania, and they're seeing lots of ROSC and increased survival from just doing that. Is it this protocol that's doing it? Probably not. It's probably a number of things, and just the fact that people are more focused on their actual CPR as opposed to anything else. Other questions? Bernie?
Do you think you're going to see a time when, because of trying to lower the amount of oxygen we're putting into the patient, we're going to be switching to using smaller size?
I can't hear.
Do you think we're going to be using smaller size BVMs so we don't increase the thoracic pressure? So, like using a child-sized bag as opposed to...
You can, yeah. So there are people who are using child-sized AMBUs. That's actually our system using that because there's a lot of air in an adult AMBU bag. Because we're so used to doing the adult one, what the guys in Seattle are doing is they're using the 3-finger technique and just giving a puff. So they do it more through training. I suspect that's probably, I think you can go either way. I don't think it's wrong to use a pediatric or child-sized AMBU. But if you get used to it, it's that 3-handed technique, that's just for training and it's probably just as effective. But you can use a child-sized AMBU, that people are using that. And
You say that PSAPs are now getting more involved with the calls?
I'm hoping. So Vermont went from a homegrown emergency medical dispatch system to a commercial protocol called PowerPhone. So the hope is that they're going to get more aggressive about doing CPR and directing CPR. Because one of the things, and this happens in New Hampshire too, I mean, I know that Cheshire does really well, Concord's about in the 60%, so I'm assuming statewide we're doing pretty good. But I can't measure, like, it's the siloed problem, right? So the PSAP in New Hampshire is totally siloed from the rest of the EMS system. So I could say that, I know all the ones that we're saying it's a cardiac arrest, we're directing CPR, but I don't know if we're missing people. And Vermont is the same way, it's very siloed. So Dr. Wolfson has been meeting with them to sort of develop a plan of measuring their cardiac arrest. And the thing is, are we directing CPR? How early are we doing it? Because a lot of systems, it may take a few minutes to get somebody on the chest. The goal should be like a couple of minutes if somebody's going to be hands on chest or on the phone as well. Really difficult. They have a horrible job. I mean, they're working they're blind. They can't see what's going on. Seattle's really aggressive. Their questions are, is the patient conscious? No. Is the patient breathing normally? If the answer is no, start CPR. And they do CPR on a lot of patients who are in cardiac arrest. They found that they're really not killing people doing it. So they'd rather not miss people as opposed to do all these other things to make sure. New Hampshire Party Dispatch uses something called an agonal tool counter. We're working on a fast track protocol, but what they'll often do is, if they're unknown breathing or they're not breathing normally, then they'll start to count. Tell me every time the patient takes a breath. Now they start to count a few seconds, so it's more time wasted. They say, oh, it's an agonal breath, not breathing effectively, start CPR, so that burns more time. So how fast can you get them on the chest? All the states, New Hampshire, Vermont, and Maine are looking to join something called the CARES Registry. It's out of Emory University in conjunction with the CDC. It's a cardiac arrest registry. We're looking to add 3 states of data into that. Part of the CARES data set has a PSAP module in it. And New Hampshire and Vermont are right for it because we don't have a lot of PSAPs that handle the 911 calls. New Hampshire has 1. So then we can kind of bring that data together and know that and break down the silo and know what we're missing and what we need to work. So I guess the short answer is they're working on it. That was sort of the long answer is what's going on behind the scenes. But we should see that, hopefully we'll see our rates tick up. I mean, I don't think people are less, Vermont. I mean, Vermonters are nice. They want to do CPR too. They just, they probably just don't have the dispatchers either aren't recognizing it or aren't as aggressive about telling them to just. Other questions? All right. Well, thank you very much.
Thank you.